Good afternoon, everyone. I really enjoyed this talk, Dr. Noor, an overview of obesity services in the Gulf region. Now, just to continue on the theme of this conference, which is that obesity is a chronic disease and that it affects literally each and every organ and system in the human body. The next session or the next talk will focus on the effect of obesity on the gastrointestinal tract with an emphasis and a focus on the liver. Now, Dr. Laith will give us a talk. Just a brief introduction. Dr. Laith is a colleague and a friend of mine. He currently works at Healthpoint Hospital. He previously worked in 2 major hospitals in England, St. Mark's Hospital as a gastroenterologist, and also in Swansea, where he was an associate professor. He is academically active. He published widely and gave lots of talks, both nationally and internationally. So, Dr. Laith.
Thank you. Well, thank you very much, Dr. Khaled, for the kind introduction, and thank you for the invitation. I would like to thank Dr. Haddad and Dr. Sarah for inviting me to this festival or movement to address obesity. And I will end where Dr. Noor finished her talk. Obesity is a multi-organ disease. It affects every part of the body, and we're going to talk about the gut in the next session. Okay, so I'm here to talk to you about the most important organ in the body, which is the digestive tract. It's the largest body organ. The relationship between obesity and digestive tract is actually a two-way thing. So, digestive system could be the cause of obesity, arguably, but also the obesity can cause digestive system issues. And as you know, obesity has been increasingly prevalent in worldwide, and as you've seen previously in the Middle East particularly. And when we talk about obesity and the GI symptoms, we are specifically saying about metabolic syndrome or diabetes. And it's well known that 75% of patients with diabetes, they have some sort of GI symptoms. One of the common referral we have in Healthpoint is from our colleagues in Imperial College with diabetic patients with several GI symptoms. If you categorize the GI symptoms in patients with diabetes, you can put them into 2 main categories. You have the motility dysfunction category, which is a gastroparesis, enteropathy, and the large bowel dysfunction. And you have also the liver-associated complication, which we will talk about extensively at the end. So I will not indulge too much into the motility because the main theme will be about steatotic liver disease, but just briefly to touch on the GI manifestation. Here we're talking about gastroparesis. So gastroparesis, as you know, is a syndrome where there's a delayed gastric emptying, which will lead to food retained in the stomach more than usual, more than 3 hours. It's a well-recognized complication of metabolic syndrome, particularly in diabetes, more common in women for unknown reasons, and affect about 2/3 of patients with type 1 diabetes and 1/3 of patients with type 2 diabetes. Whether this is directly because of diabetes or because of the medications that we are treating for diabetes. However, obesity appears to be independently predict the symptoms of gastroparesis, regardless other medications. Clinical features can be present because of nausea, vomiting, early satiety, and I've certainly seen many patients where they feel early fullness with gastroparesis, but also a hint, if you have a diabetic patient with deteriorating glycemic control, with increased variability of glucose, then you might suspect gastroparesis. Although insulin does not affect the motility of the stomach, but gastroparesis can affect the emptying of the carbohydrate and the macronutrient into the small bowel, which can affect the variability of glucose. So whenever you have someone who's got hectic glycemic control, I think we should suspect gastroparesis by asking about the symptoms. And the diagnosis of gastroparesis is mainly clinical, by symptoms, by exclusion of other possibilities, and always bear in mind whether the patient is taking any drug or medication that can cause gastroparesis, commonly GLP-1 or DDP-4 or metformin. Also opioids, especially people who are taking chronic painkillers. We do have confirmatory tests, which is the gastric emptying study, but whether you have access to this or not, I think clinically, if you suspect gastroparesis, it's more than enough for me, unless you plan to do an intervention when we have to have a confirmation of gastroparesis. Treatment of gastroparesis, there are 3 parts in managing gastroparesis. First is dietary, second is medication, and third is endoscopy or surgery. When it comes to diet, the aim is to maintain nutrition, frequent small meals, hydration, to maintain the input. And when it comes to medication, we do have a few medications that can be used in gastroparesis. Commonly are metoclopramide and domperidone. They are very commonly used prokinetics. However, when you look at the data, the clinical trials that support the use of these prokinetics are very small in size. They are commonly unblinded, but from clinical experience, metoclopramide and domperidone has been used extensively with good response. The response varies from 25 to 75%. Unlike metoclopramide, domperidone does not cross the blood-brain barrier. That's why it does not have the CNS symptoms that we all scared about when we give metoclopramide. However, these complications are more common when you have a chronic use of prokinetics. Erythromycin is a well-known antibiotic. However, it's a motiline receptor agonist and is shown to promote the gastric emptying. And we commonly give it for people with upper GI bleed before doing endoscopy, so we can empty the stomach from the blood clots. We do have other medications with variable response, but from my clinical practice, I start with metoclopramide or domperidone 10 milligram 3 times a day. If there's not enough response, then I give erythromycin 250. We do have surgical and endoscopic treatment. I'm going to talk briefly about endoscopy, which is a G-POEM, which has been developed in Japan and over the last decade has been commonly increased. And we do have 2 or 3 centers here in UAE. And basically what they do, they cut small tunnel in the mucosa just before the pylorus, and they create a third space or submucosal tunnel, and then they cut either partial or full thickness of the pylorus muscle to promote the emptying of the stomach. Obviously, this is highly advanced, specialized endoscopic procedure, and we have to have a confirmation of gastroparesis before we go ahead. The second gastrointestinal dysmotility is a diabetic enteropathy, which can affect either the small bowel or the large bowel. And it's very commonly seen in patients with diabetes. Even if we don't ask about it, it is there. And the pathogenesis of diabetic neuropathy is complex, whether this is because of the autonomic neuropathy or because of the macrovascular ischemia. And symptoms can be constipation because of delayed colonic transit time or diarrhea because of malabsorption. And when you have diarrhea, then you have to suspect other conditions such as small bowel intestinal overgrowth. Bloating is very common because slow motility can affect the absorption, leading to bloating. And commonly symptoms you see constipation or diarrhea. Treatment is commonly symptomatic. Whether this is constipation, you try laxatives. Be very mindful of the bulk forming laxatives because high fiber can induce constipation unless it's coupled with well hydration. For diabetic or metabolic diarrhea, you can try antidiarrheal drug. Obviously, you have to exclude other causes of GI symptoms, whether this is a medication-related or bacterial overgrowth or exocrine insufficiency of the pancreas or other conditions. Now, we're going to talk about one of the most common GI association with obesity, which is the metabolic dysfunction associated steatotic liver disease. And it's very, very common, and increasingly we see cases with MASLD. The name has changed recently from NAFLD to MASLD to reflect the etiology of steatotic liver disease and include the whole metabolic syndrome. There's a direct correlation between BMI, the body mass index, and the prevalence of MASLD, and almost a quarter quarter, and this is based on observational studies, almost 25% of population in UAE, they have some sort of steatotic liver disease. The new terminology has changed, and MASLD now, by definition, include any steatosis of the liver which can be picked up on ultrasound, plus one of the 5 cardiometabolic criteria, whether either high BMI or waist circumference, diabetes or hyperglycemia, hyperlipidemia or hypertriglycemia or hypertension. And once you have the diagnosis, then you go through the diagnosis of steatotic liver disease. And if you look at the data from the UK, you can see since 1970, the death because of liver disease has quadrupled. So it's gone from 100 to 400 over the last 5 decades. While if you look at the other conditions, the death related to heart disease and cancer has remained the same or has even decreased. And this is a stark difference between death related to liver disease compared to other conditions. So it's a huge burden on any health system, including the UAE. And when we talk about steatotic liver disease, it's a spectrum of conditions from pure steatosis to cirrhosis. And patients can present at any stage of this evolving disease. You can have the pure steatosis, which is a commonly benign, almost 90-95% of patients, they have pure steatosis, which can develop into NASH. Once they start to NASH, this is where we have to do an active intervention to prevent the progression to fibrosis and cirrhosis. The single predictive factor of disease progression is fibrosis and NASH, and this can be seen histologically, where you can see here. And having obesity is a risk factor of MASLD, but diabetes is a major risk factor of metabolic-associated steatotic liver disease. And many studies after studies have shown that more than 70% of patients with type 2 diabetes, they have some degree of MASLD. Irrespective of the liver enzymes, even if the liver enzymes are normal, diabetes and obesity, they are closely associated with diagnosis of steatotic liver disease, the progression to NASH, and the progression to cirrhosis and fibrosis, and even hepatocellular carcinoma. And hence, the latest European guidelines for study of the liver recommend screening for NAFLD or MASLD in every patient with diabetes, and also screen for diabetes for every patient with fatty liver disease. And in Healthpoint, we're starting one of the first fatty liver disease clinic. It's a multidisciplinary clinic where we have endocrinologists, bariatric surgeon, primary care physicians to address, give a holistic approach for those patients with fatty liver disease. When we screen for steatotic liver disease, we have 2 ways. We have the non-invasive and we have the invasive ways. The non-invasive can be divided into biochemical, and we have the imaging. The biochemical one is the FIB-4 score, which is basically relies on the age and AST, ALT, and the platelet count. It's commonly used where we don't have access to imaging, such as a fibroscan. In the UK, general practitioner or the family medicine doctor, they screen using the FIB-4 and before referral to the secondary care. Any FIB-4 more than 1 point, as you can see, this is the diagram that we used to back in the UK. A FIB-4 score of less than 1.3, this is highly unlikely patients got significant fibrosis. Any score more than 2.67, they're highly likely to have fibrosis. However, we cannot wait for the fibrosis to refer patients. We need to identify and screen those patients at earlier stage to allow an active intervention in terms of managing the risk factors and looking for any evidence of steatohepatitis. Nowadays, increasingly, we have easy access to FibroScan, which is the transient elastography. It is being commonly used, and we have one machine in Healthpoint. It's based on sending an ultrasonic wave through the liver and bouncing back, and we can measure the stiffness of the liver. We have both the ultrasound elastography, which is the ARFI, but also we have the FibroScan, which is done in our clinic. any value of LSM less than 8 is more reassuring, is less likely to be fibrosis. Anything more than 12 kPa there's a high risk of fibrosis, which will necessitate frequent intervals. For those who do not have any evidence of fibrosis, we do recommend doing the fibroscan every 2 years. However, the cutoff point is variable depending on the other risk factors as the weight and the diabetes. But roughly 1 to 2 years is a good interval to screen those patients using fibroscan. Obviously, the liver biopsy is the gold standard tool to diagnose, stage, and risk stratify patient with fatty liver disease or steatotic liver disease. However, it is invasive. People don't like it, so we rely increasingly on non-invasive measures unless we want to confirm the diagnosis or we have suspicion of other conditions such as autoimmune hepatitis and fatty liver disease. And we do have few cases of autoimmune hepatitis and fatty liver disease. And when we talk about treatment, there are 3 main elements of treatment of steatotic liver disease. We'll start with diet and lifestyle changes, then we have the pharmacotherapy, and finally we have the surgery. And when we talk about diet and lifestyle changes, it says it's a comprehensive approach, including regular exercise. Our aim is 5 to 10% of weight loss, and studies have shown more than 7% is associated with histological regression of fibrosis. And we have excellent dietitian in Healthpoint, where we refer a patient with fatty liver disease. There are many diets we recommend for fatty liver disease, commonly the Mediterranean diet, but also the intermittent fasting has proven to be very helpful for those with fatty liver disease. When it comes to exercise, any exercise is better than not exercising, whether this is aerobic or resistance training. It's very helpful and improve the long-term outcome of patients with steatotic fatty liver disease. And it's a comprehensive lifestyle approach in terms of increasing the antioxidants and reducing the carbohydrate and high sugar and high saturated fats, increasing the activity, and also the timing of the food is very important. I tell patients to avoid late evening meal. I have many patients who come and says, I have 1 meal a day, but when you ask deeper, it says, I have 1 meal before I go to bed. So you remember the metabolism is more during the day, so having late evening meal, even if it's single meal, is also associated with fatty liver disease. Pharmacotherapy is very exciting, and it has changed in the last year or two. We reserve pharmacotherapy for patients with evidence of fibrosis or histologically proving steatohepatitis, because remember, these are the 2 stages that has poor prognosis of patient with fatty liver disease. And if you asked me to present this talk 2 years ago, then at that time, the field of hepatology had many negative emotions, and we had, very disappointing clinical trials, as you can see. And this is the graveyard of all the clinical trials, whether this is small or big companies. There was no success, and until recently, we did not have any FDA-approved medication for steatotic liver disease. However, it's my pleasure to say that since March this year, we have the first FDA-approved medication, which is thyroxine receptor agonist, or resmetirom, as I'll show you in a minute. It has been approved in the States. It's coming to have approval in EU very soon, and hopefully, inshallah, we'll bring it to UAE next year. And the clinical trial has showed that resmetirom has significantly improved the fibrosis stage, and this is a biopsy proven improvement in both fibrosis and steatohepatitis. And if you can see, look at the data, they compared 2 doses of resmetirom, 80 and 100 milligrams, compared to placebo, and you can see there's at least 12% difference, delta change between the active intervention arm and the placebo. Although 12% is not a significant number, but it's statistically significant, but also fibrosis, we know to move fibrosis is very, very difficult, and to have an anti-fibrotic medication is very exciting in the field of hepatology. And when we look at the subgroup analysis of those patients who responded to resmetirom, although it has made an overall response to resmetirom, those with body weight less than 100 kilograms, they responded better to medication. So still weight loss is an element managing patients with steatohepatitis. And now moving from resmetirom to a drug that you all know, tirzepatide, which has been used in diabetes successfully, as you can see on the left side. However, latest publication has shown that Mounjaro, GLP-1 and GIP agonist has a role in improving fibrosis and steatohepatitis in patients with the steatotic liver disease. As you can see, the delta wave between those who had tirzepatide and those with the placebo is at least 20%, which is quite significant. However, I don't want to sell this as a drug for steatotic liver disease. This is still phase 2 clinical trial, and we're still waiting for the phase 3 before we can say Mounjaro or the dual GLP-1 GIP agonist is effective in steatotic liver disease. But this is promising. The way this works is not directly on the liver. It works by improving the metabolism of the body generally. However, there is a new medication which is coming on the horizon, which is survodutide. This one works on the glucagon receptor agonist, which is in the liver. So while tirzepatide works on the general metabolism, we have the new agent which is on the horizon, and you can see this is again another clinical trial. It's a phase 2. We show the significant improvement in terms of histology, in terms of fibrosis and steatosis between those who had a placebo and those who had survodutide. So it is exciting field to be around. We know pharmacotherapy will have a role in the next year or two. It is expensive therapy, but obesity is an expensive and huge burden on the healthcare sector anyway. Other common questions we ask about what is the role of statin in steatotic liver disease. So the lipid-lowering agents, they haven't been adequately tested in steatotic liver disease. However, it's very important to address the risk factor in terms of hyperlipidemia. There is no contraindication to use a statin in patients with fatty liver disease and well-compensated liver disease. Yes, if there is 2 to 3 times increase of liver enzymes, then we would recommend changing or switching the statin to something else. When it comes to vitamin E, there was promising data to start with. It does help with the steatosis, inflammation, but there is concern about the long-term safety of vitamin E, so it's not one of the highly recommended these days. We're more focused now on the pharmacotherapy. And obviously, surgery and bariatric surgery has a major role in patients with steatotic liver disease. A lot of observational studies has shown a positive impact of bariatric surgery on fatty liver disease, whether this is on a long-term outcome or short-term outcomes in terms of improving liver enzymes. And I have seen this because we work with excellent bariatric surgeons in Healthpoint. All the patients being referred soon after the bariatric surgery, the liver enzymes goes back to normal. However, until recently, we did not have a randomized controlled trial. And the BRAVE's clinical trial, which is published in Lancet GastroHub just last year, is the first randomized control study which compared lifestyle modification with bariatric surgery in patients with steatotic liver disease. They observed them for 12 months, and there were 3 arms of those patients. The one who had lifestyle modification, including exercise and vitamin E, and those who had Roux-en-Y and who had sleep. And you can see there's a significant regression and improvement in both steatohepatitis and in fibrosis, which is very promising. So the bariatric surgery does not only address the other metabolic syndrome component, which is the hypertension and diabetes, but also prevent the long-term damage to the liver. This is important because until now, fatty liver disease or steatohepatitis is not taken seriously when it comes to consideration of bariatric surgery. I think the future guidelines will include bariatric surgery as an indication, include steatotic hepatitis or fibrosis as an indication for bariatric surgery. And this is the first clinical trial. There are 2 other clinical trials which are waiting for the outcomes by the end of the year. Again, the data are promising. I had to look at them at EASL in April this year, but this is the first published one, and clearly the results are promising. With this, I would like to thank you all, and again, thank you for listening. I will share with you the picture of our great endoscopy team in Healthpoint, and thank you very much.
Thank you very much, Dr. Laith. Fascinating talk. I have certainly learnt a lot. Any questions from the floor? Yep.
Hi, Laith. Thank you for your excellent lecture. This is Gautam from MASLD CLN. Historically, as diabetologists, we have used pioglitazone in our MASLD patients. What's your recommendation of a good old friend pioglitazone in the current context of MASLD?
Thank you very much. I think pioglitazone, I have used it myself as well as metformin in the past. It has a promising initial data, but nowadays been removed from the guidelines because of the side effects and the lack of documented evidence behind it. But now we don't recommend it anymore. But thank you. Very good question.
Yeah, thank you. Any other questions? When do you do a liver biopsy on patients with a suspected fatty liver disease?
Thank you. That's a very clinical question. And I would consider biopsy in the current scenarios. First of all, if I suspect someone's got an overlap syndrome, and I have seen especially patients with type 1 diabetes where I suspect an autoimmune component, if there is uncertainty about the diagnosis, I would consider the liver biopsy. Because remember, those patients, if they have fatty liver disease and they have autoimmune hepatitis, if I give them steroids, it will worsen their fatty liver disease, but might improve the autoimmune disease. So I would do it if there's an uncertainty about the diagnosis. I would do it to assess if patients got element of fibrosis or cirrhosis. If they radiologically look like cirrhotic or fibrosis, but we don't know, I would do the liver biopsy for those patients. The third indication is when you want to enroll those patients for clinical trials. All the clinical trials necessitate a liver biopsy. Obviously, this is an academic reason, but we don't do it in clinical practice.
Thank you. I have a question for you, Dr. Laith. You presented some data on the thyroxine receptor agonists. The improvement we see in fatty liver disease with this new drug, is this related to weight loss or completely unrelated to weight loss?
Thank you. So weight loss was actually associated with the general, with the study, but the theory behind this, the thyroxine receptor does exist in the liver and has a role in the accumulation of fat and triglyceride in the liver. So by stimulating the thyroxine receptor, it will reduce fat content or steatosis in the liver. So it does not work on the weight, but weight was part of the clinical trial. And the sub-analysis that I showed later on, those who had weight less than 100 kilograms, they responded better to resmetirom compared to those who had more than 100.
Certainly a very interesting area. Now, my last question to you is that you showed us a very interesting slide showing the rate of death from most diseases now have gone down except for liver disease. Do we know the proportion of patients who are dying because of liver disease caused by fatty liver disease? Because obviously there are different causes for liver failure, including alcoholic liver disease, infective. Is cirrhosis and death because of cirrhosis related to fatty liver disease increasing because of fatty liver disease?
That's a very important question. We don't know for sure what's the proportion of those who are dying because of decompensated liver disease from steatosis liver disease or the none. But the 3 common causes of what I've shown is viral hepatitis, liver cirrhosis, and alcohol liver disease. And it depends where you are in the world. In the Western countries, definitely the viral hepatitis is going down, alcoholic hepatitis and fatty liver disease is going up. In other areas in the world, still viral hepatitis is common. But I don't have a data exactly how much is steatosis steatotic liver disease compared to the other causes of mortality. But what is interesting, in the 4 times fold increase in mortality, these 3 common causes are preventable. So whether this is steatotic liver disease or viral hepatitis or alcoholic liver disease, they are all preventable by lifestyle changes.
Okay, well, thank you very much. Yes, one last question then from the floor.
Hello. First, thank you so much for the informative presentation. My question is regarding the lifestyle modifications, the macronutrients composition. You mentioned 2 opposite recommendations, a high carbohydrate diet and low carbohydrate ketogenic diet. So according to which criteria you decide to choose a high carbohydrates or a high protein diet?
So I refer to dietitian. I personally recommend intermittent fasting, but this is what the guidelines has mentioned, especially EASL. We have a lot of studies comparing both different diets, but there's no such strong evidence behind a particular type of diet. You know, there is another publication about the different types of diets, but when I looked at the data, there's no enough data to recommend one particular diet. So that's why I leave a dietitian to deal with it.
Just to add my voice to yours, I mean, I think 7% weight loss, as you've shown, you know, dramatically improves liver structure and function. Okay, well, thank you very much, Dr. Laith, and I think next session.